Hey guys, welcome to this pharmacology drug class review on our bronchodilators with a specific focus on the long-acting beta agonists. You know, the long-acting beta agonists are some of the most effective symptom control drugs that we have for asthma and COPD, especially when used appropriately. Why? Because they keep the airways open and relaxed for that 12 to 24-hour period. And this dramatically cuts down on our day-to-day symptoms of feeling out of breath and also the nighttime symptoms that then eventually translate into impact on daily activities, quality of life, and also reduce unnecessary office and ER visits. That makes learning these drugs actually fairly relevant. And on that, I'm Dr. Busti. Thank you so much for joining me on This Is Why, a show that is dedicated to helping us as healthcare professionals understand why we do the things that we do. That includes pharmacology and the drugs that we use every day, because when we understand the why, the how and management of patients becomes easier, and those mechanisms that we learn, the side effects, and everything that we start to memorize start to make sense when we connect the dots and we understand the why. All right, now, just like with all of my drug class reviews that I provide, we cover core content, we address the agents, common uses, net benefit, then we dive into that pharmacology. In this area, we're going to look at some anatomy, we're going to consider drug dose and mechanisms of delivery, because there's a lot of different dosage formulations that we consider with bronchodilators, and it's important to recognize where they are similar, but also where they are different and or unique. And then we'll transition into that clinical knowledge application and those pearls that we all wish that someone would have told us. Okay, so let's dive into the agents. We have options here mainly in the chronic care environment. We should not look at long-acting beta agonists for acute control of symptoms. The exception, and I say small exception, is Formoterol. It's the only one that probably can offer a little bit of earlier onset and some benefit, but really we should not think about these drugs for acute management or acute unstable conditions for obvious reasons that they are preventative in most cases. So we have Formoterol, we have Formoterol, Olodaterol, Salmeterol, and Vilanterol. And these drugs have been around now for several years, and I think this drug class and the combinations available for patients to use has significantly improved. Many of these drugs, as we're going to see here, are not used as monotherapy, and that's really important take-home point. They are many times in combination with other drugs and formulated as such. Okay, now we're going to move into our indications and common uses, which may seem straightforward. Yes, asthma, COPD, those are the mainstay. But don't forget about also exercise-induced bronchospasms, where we are increasing that minimum ventilation during our exercise that can sometimes be irritating to the bronchioles and cause bronchospasms. Again, we're going to look at some of that anatomy here in just a minute. Now, I do want to point out and show you a table. Again, these tables, just like all of my lectures, are available for free download at thisiswhy.health. We put the link in the description of the episode, whether you're on our podcast channels or on YouTube. You should be able to access that page where these are available for you. This is a basic summary of asthma versus COPD. It doesn't include exercise-induced asthma. It doesn't include other obstructive airway diseases like bronchiectasis, even cystic fibrosis. I'm not saying those aren't important, but the mainstay of treatment and the indications and uses are centered around these. It's important when we learn bronchodilators and other inhaled drug therapy that we put them in the context of the pathophysiology and also characteristics about the disease. Now, this is not the end-all, be-all summary of all pathophysiology for both of these conditions. It's rather complex. However, at a high-level observation, this is very helpful, in my personal opinion, wrapping your mind around this, especially if it's new in your training. So on the left-hand side, you see that we have the variable, things like the cell type, and I'm talking about immune cells, airway activity, is it hyperreactive or not? What is the likelihood of a bronchodilator response? And ICS stands for inhaled corticosteroid response. When do we use them? There's subtle differences, and it's important. Sometimes we start out with one agent first in one group, and then we add on other agents as we go through, and that's flipped in the other disease state, and that's why it matters. So when you look at asthma, which is in the middle, COPD, which is on the right side, we see that asthma's primary cell type is eosinophils. That's more related to allergies and allergic reactions and those kind of things, whereas on the COPD side, it's neutrophils. Why? Because there's constant exposure to environmental things that basically trigger the immune system to have to clean up mess and try to phagocytize things and create inflammation that then results in overall remodeling. And so when you look at the airway activity, asthma is considered a hyperreactive airway disease. And being hyperreactive, it's typically due to spasms from inflammation, irritation. Yes, it does produce some mucus, and patients can develop mucus plugs, just like in COPD, where we have inflammation also of the airways, but their airways are edematous and they produce a lot more secretions. That's why patients go through that phase of bronchitis, where they have that wet, productive cough that you can see sometimes with viral bronchitis, right? But they're not having as much vasospasms. They just have thick mucous membranes producing lots of mucus that can obstruct eventually that airway, and chronically over time, there's remodeling. And the reason that remodeling is relevant is it relates to the third item, which is about the bronchodilator response. For asthma, it's much better. Okay, we get a greater return on investment of administering that medication in that patient population. Whereas in COPD, because of the remodeling and the thickness of the mucus production that we'll see here in a minute, it's not as strong. As it relates to inhaled corticosteroids, even though both are inflammatory in nature, inhaled corticosteroids are the mainstay of treatment. First-line therapy, should always consider that before using any other drug therapy in asthma. Whereas in COPD, they're typically added on later or in moderate to severe disease. Now, I want to point out another condition that is relevant in the context of indications and uses. Okay, so you just saw some variability, and maybe there's a few areas that are less clear, fuzzy, gray zones. Why does that happen? Well, this particular Venn diagram kind of structure is trying to show you there's some overlap between these obstructive airway diseases. So we have asthma, which is our classic hyperreactive airway disease, and then we have COPD, which is really an evolution between the development of chronic bronchitis that over time starts to cause remodeling of the airways, where they lose their walls, compliance, strength, and they start to collapse. And that remodeling, it results in emphysema, where there's air trapping. So in both cases we have air trapping, but the reasons for the air trapping or obstruction are different. But there is some overlap, and that is what is identified here as ACOS. That's asthma COPD overlap syndrome, ACOS. And that's important because some patients with COPD will also manifest or have symptoms associated with asthma, that hyperreactive component, where they will benefit from certain types of bronchodilator therapies and preventative medicines. Okay, vice versa, there's asthmatics who have components of obstructive airway disease and that fits the pattern of COPD. And so it's important to recognize that these conditions sometimes go on a spectrum, but then there's also some shared similarities. And that's where we need to listen to our patients, where we implement certain drug therapies, but we need to consider the modification of the drug therapy as they communicate back to us on their symptom control, because we want to keep them out of the hospital, we want to keep them out of the clinic, we want to keep them functional and improve their quality of life. Okay, that was a high overview meant to just orient you, but now we need to kind of move into that net benefit. Why would we pick the long-acting beta agonists if we're not using them as monotherapy, especially in asthma, and where inhaled corticosteroids are? Well, remember, they're very selective for bronchodilation via the beta-2 receptors, and they can be used as a background component to both asthma and COPD. That's very helpful. Okay? They're known to reduce those daily symptoms, both at day and at night. What night? Remember, we don't want people getting bad sleep. We need that rest. And so if they're waking up coughing because they have spasms and things like that, they're not getting that rest that's needed. When you look at the pulmonary function test, there's improvements in airflow, Okay? Again, that's manifest in their symptoms and their quality of life. And then lastly, at the end of the day, here you see the evidence suggests that long-acting muscarinic antagonists are preferred. So that's when you were, like, if you're trying to think, well, wait a minute, if I can use it for asthma and COPD, what about those anticholinergic drugs or anti-muscarinic or muscarinic antagonist medicines? Yes, and when the two compared, anti-muscarinic antagonists tend to work a little bit better. Now, you say, well, why is that a net benefit? It's in the fact that you're going to see these drugs being used in combination because we have multiple drug combinations now available in formulation because, again, of those overlaps where we might see one symptom over another. But long-acting beta agonists clearly have a role. Okay, now we're going to shift into that pharmacology, and when we do, part of what I want to do first is just orient us to some anatomy and visuals of the patho, because it's really important about these drugs that we get them to the site of action. If you don't get it to the place where it's supposed to work, it's irrelevant. Drug sitting in your oropharynx doesn't bronchodilate the airways, period, right? So that's why we have proper techniques, dosage forms, different mechanisms to get that drug down there, but there's even the technique of the patient participation that becomes relevant, but it's all explained by why, and the why of that is explained by the anatomy. Okay, so what I have here is a diagram for you, just looking at the basic anatomy. Obviously, we have to inhale these medications in most cases. There are some parenterally administered medicines that can do that we can give it IV, IM, sub-Q, things like epinephrine and things like that can bronchodilate. That is really not the intent or focus here. We are talking about more inhaled bronchodilator therapies. So the assumption is that we're topically administer them by inhalation. Well, they have to, that medicine has to come out of the inhaler and go through the oropharynx and move down the trachea into the larynx and the bronchi, okay, right here, and go to each direction. Now you'll see there's a lot of rings here. And they're extending all the way down pretty far deep. And those are cartilaginous rings that are meant to facilitate and hold that airway open. That doesn't mean that the airway still can't occlude. The tissue around those cartilaginous rings can become edematous, and they can start producing mucus. But we've got to get these medicines not right there. Those airways are held open largely by those rings. We've got to get it down here to these bronchioles. And so what you see with these band-like wraps that are going on around that area, those are smooth muscle. That's smooth muscle. And that's the area where the bronchospasm that leads to cough, feeling short of breath, the symptoms that affect quality of life, is like right in this area. And that's right before we get to the alveoli, where that gas exchange is occurring. And so, obviously, if you constrict the bronchioles, you reduce the delivery of oxygen to that alveoli, but you also prevent the removal of CO2. Patients don't feel well when they start to become hypoxic. They start to become hypercapnic when they have obstruction, okay? So you have got to get the drug down to that area. Now, if we kind of zoom in a little bit closer and we think about the concepts that are happening here, the alveoli have a lot of blood vessels. You've got arterioles coming in, and you've got venous blood going out, right? And so as you are doing that, that's all about gas exchange. And so if you've kind of visualized the alveoli over here at the very end, where these real thin basement these membranes, where there's gas exchange happening. So as the blood is coming by through the pulmonary artery and eventually makes it down to these arterioles, it's deoxygenated blood. It's got to get that oxygen from the air that we breathe in. It crosses over through a concentration gradient, okay, and diffusion into that blood, and then as it also is passing through, it removes the CO2 that it came from the body, from the metabolism, byproducts of metabolism, and then we would blow it off. So there's oxygenation, which is the air coming in, and we oxygenate the blood coming through, and then there is a ventilation, which is the removal of CO2. So, but if I collapse this airway, and I can't do that, I will impact both oxygenation, but I will also impact ventilation, the ability to remove CO2. And so this is what happens when patients get into more severe exacerbations, whether it's COPD or asthma. That's why their acid-base levels start to be affected. Now, when we start taking that concept and we think about asthma and COPD, this represents some of that bronchial tissue up here, okay? So this is another sort of drawing rendition, normal-looking lung airways with muscles that are going to expand, contract based on the needs of airflow that we need. As the tissue gets irritated by those eosinophils and start release cytokines and stimulate the allergic and inflammatory response, especially if we're not adequately on an inhaled corticosteroid, which also has to get down to that area, you start to see that the tissue becomes thicker and more edematous. Well, look at the lumen of that airway. It's being compromised. All right, so that's less air moving in. You see all the swelling and bulging around the smooth muscle during some degree of symptoms. Maybe the patient's not like grossly short of breath, but they're not feeling great. And then all of a sudden they start to have severe tightness, right, where there's actually more mucus being made and they can form a mucus plug. And then that tightness and that spasm, hyperreactivity, that's where we need the drug, way down here. That means you have to use the right technique, the right methods, the right type of dosage form to get it to this site. And when we think of long-acting beta agonists, these are for chronic kind of preventative symptoms, not in acute exacerbations. So we need to get those drugs delivered down there, whether it's an inhaled steroid or a long-acting beta agonist. That's just true for all of them, guys. It's really important that you see that. Now, in the context of COPD, you go through that phase of bronchitis where there's a thickening of the wall, but there's a lot more mucus being produced, okay, even in the higher up airways where those cartilaginous rings are. And then over time, okay, what ends up happening is you start to see the remodeling of the alveoli and the bronchiole where they lose the ability to make mucus, but they're also weak walls and there's collapsing. So their ability to respond to a bronchodilator, even a long-acting one, is less in COPD compared to asthma. And that's why that table I showed you says that. Okay? That is the why behind it. Now, what's going on when I get the drug down here to the bronchiole? It has to bind to something. And so it's a long-acting beta agonist. So what are we talking about when we say beta agonist? Okay, so this particular image shows you the kind of intracellular chemical reaction, the cellular physiology that's going on that causes that smooth muscle relaxation that relaxes the spasm and opens up that airway at the bronchiole, right, predominantly. So I've listed here the albuterol as the classic drug, but quite honestly, and that's a shorter acting one. It's true for the other ones. The ones we're talking about, the long-acting, what makes them long-acting is their ability to embed and kind of interact with the beta receptor, which is kind of embedded in the cell membrane. Once you bind to it, it's activating it. So it's a beta-2 agonist, okay? It's activating that beta receptor. And that turns on adenylate cyclase inside of the cell, which then converts that ATP to cyclic AMP levels as they go up. That raises also then the activity of protein kinase A, which does two things that are important. It decreases the phosphorylation of myosin, which remember, actin and myosin are needed to interact for muscle to contract. So that phosphorylation is necessary for contraction. Well, if I decrease phosphorylation, I decrease the ability of actin and myosin interaction, but I also reduce cytosolic calcium concentrations. Calcium is also an essential component for that actin-myosin interaction that allows smooth muscle to contract. So if I remove those two chemical components intracellularly, I'm going to result in less interaction, and the net overall effect is bronchodilation. Well, why would I spend time talking about this? It's not meant to just try to impress you with a bunch of biochemistry and cellular physiology and anatomy. but it explains why certain answers on even certain exams and why certain drugs work in certain situations where we may use combination because someone's on another medicine. I got to bypass that mechanism to dilate them because they're occupied. So for example, when someone's on a long-acting beta agonist, giving them a short-acting beta agonist, that means those receptors are occupied. So I've got to bypass that mechanism to a different way of dilating those airways. But on a board exam, for those of you taking those, I can ask a mechanism of action question probably 4 or 5 different ways, and they're all accurate. I can say that, these drugs reduce cytosolic calcium, correct. These drugs reduce myosin phosphorylation, correct. They reduce the interaction of actin and myosin in the smooth muscle tissue of the bronchioles, causing bronchodilation, correct. They interact with the beta-2 receptor in an agonist activity, correct. You see, it's important that you don't just memorize one thing or the drug class, but you need to understand the mechanism because that translates into why we see the therapeutic effects that we see, okay? Now, when we think about some of the pharmacokinetics and dynamics, what makes them long-acting agents versus the short-acting agent like albuterol? Again, that has a lot to do with the binding affinity or the solubility and interaction with the receptor in that cellular membrane. And so what ends up happening with the long-acting drugs is that they're more lipid-soluble than our short-acting agents. And so they allow that to penetrate the cell membrane and interact with those phospholipid membranes a little bit longer. And so that improves the overall effect throughout the day. And again, some of them are longer than any others. Some of them have to be dosed twice a day, but some of them are dosed once a day. Now, long-acting beta agonists also tend to be more selective. Okay, there's not, beta-1 receptors are in other places in the body, like the heart. The reason we administer medicines like this topically is that we're trying to reduce the systemic absorption that would cause more systemic side effects. But there is a dose response curve. And what I mean by that is when you have when you're using these to bronchodilate them via beta-2 receptors, when you have increasing bronchoconstriction of that image going back, the further it goes along, the longer you wait, the more drug you're going to need to exert the desired therapeutic effect in that bronchiole. And that's why when patients actually come into the emergency department, we're giving them back-to-back treatments at much higher doses because we have to overcome these shifts basically in the pharmacodynamic response that particular dose. It loses essentially kind of a sense of potency and effectiveness, okay? Now, when we think about long versus ultra long, this really comes down to that lipid solubility and the interaction of the beta-2 receptor, but it translates into the so what, who cares, the why, by the frequency of administration. Okay? So our Formoterol, Salmeterol, typically dosed twice a day because of their roughly 12-hour duration, whereas Vilanterol, ultra long acting beta agonists can be administered once a day. Well, why would we want, who would rather do a drug once a day than twice a day, right? I mean, that's just common sense for a compliance adherence to the thing that's going to help patients to feel better. Now, unfortunately, when we occupy receptors, especially chronically, and at high constant interaction, our body, our biology can start to downregulate, basically pull down, or change the affinity of those receptors to say, okay, hey, wait a minute, whatever that thing is over here, it's too much of it, we need to stop. Too much stimulation going on here, let's back off, okay? And so that desensitization that can occur can also impact sometimes the underlying efficacy, but we see that with chronic high-dose therapy. Adding on steroids, okay, especially in the acute, like systemic steroids. We use them in the acute predominantly. We don't like to use systemic steroids chronically, obviously, for all the side effects they come. We go to inhaled steroids for prevention, but in the acute, we can sometimes reverse some of that effect, and then basically what happens is the duration of bronchodilation of action of those medicines improves. And again, that's why in the acute phase, we'll use a round of a few days of oral or systemic and steroids many times to calm things down. All right, now we're going to move into the clinical knowledge application piece. And this is where we kind of dive into some of the practical pieces of getting that drug to the right location. And this is really important for not only compliance adherence, but it's improvement in those symptoms. So if you don't understand that stuff I just explained a minute ago, it doesn't make sense to you, you need to stop and rewind and listen to it again. I would highly encourage you to do that, because the next couple of slides are really trying to talk about methods of getting the drug to the right location in that bronchiole. So when you look at our options, this is just a number of images that represent different dosage forms. They're not meant to be representative of all the drugs that we're talking about in the long-acting beta agonists. But we have aerosolized with different types of propellants. We have those that are used with spacers and without spacers. This is your spacer. That's kind of what it looks like. It's a holding chamber, far more effective than just using it without. Then we also have dry powder inhalers, and they look different, different shapes, functionality, how they work. They don't need to be shaken up. They're not pressurized. All that stuff influences our counseling points. That's why we understand that. And then, of course, our classic nebulizer machine, where people many times think, oh, because the sick people get the nebulizer, it must be better. The evidence does not support that. Okay? We have got to get the drug down to the site of action. So there's a proper technique, and it is different depending on which of those methods of delivery that you use. Okay? This is a diagram that represents the steps that you go through from the left side, where number one is you remove the cap. Then number two is if you're using a inhaler with some form of propellant or mist creation, you've got to shake it many times. But if you're using a dry powder inhaler, which many of these are formulated as, okay, Formoterol comes in a formulation that's given as a nebulizer, right? So you have to know the drug and its formulation options that influences the counseling and the methods of administration. But you're not going to shake powder devices, dry powder inhalers. You activate it. And so there's like this little button here that you bend over, push over, and it clicks, it perforates the dose inside to release the powder. And then you then have to prepare yourself to get it into the body, right? So it's either going to be propelled into your mouth oropharynx, or you're going to inhale and generate the inspiratory pressures necessary to get it in. Most of the time you're going to be using these. Well, why does that matter for me to stop and say that? Because the inspiratory pressure or flow rates that you have to generate are greater with a dry powder inhaler than with an aerosolized or pressurized propellant-mediated inhaler. Because you have something pushing it out versus something that needs to be sucked out. And so if you use the wrong inhalation technique on the wrong formulation, you will not get the deposition in the right location. So normally we have patients exhale, and then we put the inhaler up to their mouth. And again, the type of inhalation, the degree of inspiratory flow rate is greater for dry powder inhalers. Inhaling too fast, too quick, the metered-dose inhaler will cause more oropharyngeal deposition. And then what ends up happening is you try to hold your breath. So remember, we're getting it up out of this device. We need to get it down through the trachea, down through the bronchi, go all the way to those bronchioles so that it can deposit. So we hold our breath to get the airflow to stop and that aerosolized drug to deposit on the right area of the tissue so that it can work. And holding your breath for 10 seconds and blowing it out then allows, versus going, you're going to blow out at some level some of that drug, and you're going to lose the efficacy. So it's even a slow breath out that helps you in that process. So that's important, guys. Make sure you understand that. I will beat that to death because I can't tell you how many patients, when I ask them to show me how they use their inhaler, they royally mess it up. And I say, well, didn't anybody ever talk to you about it? And they usually say, no, just give me the medicine. Right? So that's our job as healthcare providers, whether you're a nurse, a pharmacist, a physician, we all are responsible at every level of the step to make sure patients know why they're taking the medicine and then how to use it properly. Okay? Some of these, even come with capsules. So like, I don't want the patient swallowing the capsule. The capsule goes in the device, you perforate the capsule so they can inhale the powder. Right? That stuff matters. So what I'm trying to show you here is the combination of a long-acting beta agonist, which I've listed here in the front, combined with a long-acting muscarinic antagonist. And again, this is going to be great for COPD patients. Because I remember I mentioned that a little bit ago, that the long-acting anti-muscarinic drugs probably a little bit more effective in COPD than the long-acting beta agonists. But remember, there's overlap in some patients. And so having formulations like these where they're mixed with those anticholinergic or muscarinic antagonist drugs, right, like tiotropium, aclidinium, those medications, those are really important. Those medicines are excellent at doing that. Now, if you have that overlap syndrome, or a patient that has more moderate severe COPD and or asthma, then that's where the inhaled corticosteroid is beneficial in COPD. Now, for asthma, remember that we want that inhaled corticosteroid first. You should not be on a monotherapy long-acting beta agonist. If you see that on an answer question for like a test, that is wrong. Okay, you always should have an inhaled corticosteroid first and then add on the long-acting beta agonist afterwards. And then now we have triple therapies where we have the long-acting beta agonist combined with the long-acting muscarinic antagonist with the inhaled corticosteroid. Again, that's nice. Many of these options allow you to administer the medication less frequent, and you get the maximum amount of airflow, which translates into improvements in symptoms. Now, I've already mentioned contraindications. You're not going to use these drugs in acute, and you're not going to use it as monotherapy for chronic, okay? When you think about the reasons why, remember you're occupying beta receptors and you're not treating the underlying problem. Go back to that slide I was talking to you about the big problem. Remember we have inflammatory cells in asthma, eosinophils. Those are going to be regulated and controlled from being exacerbated that cause the hyperactivity by preventing them from getting active. Well, that's an inhaled steroid. So if you are giving somebody just a short-acting or a long-acting beta agonist, you are literally treating symptoms and you're not treating the underlying problem that's appropriate for the patient. And so you're occupying these receptors with a drug that's really not treating the problem, so that when they have an exacerbation or they really find themselves in trouble, our options to bronchodilate them get very limited. We have to pull out things like ipratropium on multiple nebs. We have to use magnesium infusions, right? There's other things you can do, but it's really difficult in those patients. And once that airway occludes and you get true bronchospasm with occlusion and a mucus plug, you ain't getting there past that. No drug's getting down there. That's why you want to get to the area in asthma for prevention. All right, really no major laboratory monitoring needed. That's different for short-acting, where we can see changes in potassium depending on the amount of short-acting beta agonists that we're using. Lung functions, we usually obviously have a baseline, knowing what their pulmonary function tests are, their FVC, FEV1s, FEV1 ratios, those kind of things. And then we monitor them, especially in asthmatics. We look at their they can do peak expiratory flows at home with their device where they can measure this with the peak flow meter. And that helps to identify in asthmatics, not COPD patients, but in asthmatics it helps to identify the arrival of pulmonary symptoms that is getting ready to be an exacerbation if you don't get control of it. And that's where the asthma action plan becomes very relevant and helpful. And then of course in our patient with a asthma COPD overlap syndrome, this is where they're going to use a combination of modalities because the pulmonary or peak flow meters don't really indicate or give us guidance in COPD. It's like they do in asthma. Okay, so this was the long-acting beta agonist bronchodilators. Very important for asthma, COPD, also used for exercise-induced asthma. Remember, they bind to that beta 2 receptor, turn it on. That reduces our cytosolic calcium levels, the phosphorylation of myosin, that reduces that active myosin. We relax that spastic, hyperreactive airway to allow then that oxygenation and ventilation to be able to take place. And if we don't, then we're going to occlude and we're going to start retaining the CO2 and reduce this O2, which creates an acid-base disturbance, which is typically respiratory acidosis over time. These are fairly well tolerated when used appropriately. No major side effects or monitoring parameters really needed other than symptoms and their lung function. Okay, so I hope you found this to be helpful. Thank you so much for joining. I hope it put things in the context of the overall management of asthma versus COPD, where they're similar, where they're different. So important to really get that down. You know, if you're new to this topic area, you're just learning these things, many times you have to repeat this and let this stuff soak in, come back to the lecture, repeat it. It really starts to set in when you understand why you're doing what you're doing. It makes sense of the how, right? That's how to manage these patients. So also, again, you can get those images over at thisiswhy.health, as well as access to many other things like playlists, collections, coupons, other things. So I'm Dr. Busti. Thank you so much for joining and investing in your knowledge. Never stop learning the why, because it makes that how much easier. Take care. We'll see you next time.